Well, hi, everyone, and welcome to our April prep webinar. My name is Dawn Reinhardt-Wood. I'm one of the faculties with Rutgers University School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions, and one of the faculty consultants with the State Hospital Psychiatric Rehabilitation Initiative, or SPRI. Today, I'm joined with my colleague, Jennifer Sperduto, also from SPRI. And I will be introducing Dr. Shelley Buchbinder to present our topic of racial trauma-informed services for this month's prep webinar. This presentation is sponsored by the New Jersey Department of Health, Division of Behavioral Health Services, and the Rutgers State Hospital Psychiatric Rehabilitation Initiative. Welcome. Next slide, please. So this is an interactive training. We encourage you to ask questions and participate throughout the session. A recording of the webinar will also be made available after the presentation on the Rutgers SHPRI website. You see the link here, and we will also drop that into the chat. And thank you, Shelley. I appreciate that. Next slide, please. So for a disclaimer, the Psychiatric Rehabilitation Education Program, PrEP, is an online forum for a variety of topics relevant to the state psychiatric hospital staff. And while Rutgers and DBHS are co-sponsors of this program, the PrEP webinars are peer presented, and as such, content is independently developed by the presenter each month. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. Also, please note that the session is being recorded so that you have the opportunity to view it at a later date. So anything you say in the chat or by voice will be recorded. So we just ask you to be mindful of that. So now I have the wonderful opportunity to introduce today's presenter. Dr. Buchbinder provides training and technical assistance to supportive housing providers, our CSS programs here in New Jersey and Washington State, like me, yay. She teaches social work and psychiatric rehabilitation courses, and she's taught classes on race, ethnicity, immigration, and urban diversity. Her current research projects include evaluating health profession publications for health equity. She has a PhD from the City University of New York in environmental psychology. With that, I'm happy to introduce Dr. Buchbinder.
Thank you so much, Dawn, and thank you to the State Hospital Psych Rehab Initiative for the invitation to be here today, and welcome to everyone who's here live. So in this brief prep webinar, there are 3 learning objectives. The first is to be able to, at the end of this webinar, identify exposures and effects of racial discrimination and trauma. The second is to identify assessment tools and screen for racial trauma and PTSD, focusing on PTSD caused by racial trauma, and then to identify resources on racism, implicit bias, and cultural humility. So we'll end with some resources. And before we really get started in the content, I wanted to have a moment to reflect on positionality because I was asked to do this webinar about 2 weeks ago. And my first reaction was both to myself and to the people who run PrEP was, why me, right? Why me as a white woman should I be talking about racial trauma? And upon reflection of my own positionality, my own experiences, I came and discussion with them, I decided that this was a good topic for me to talk on, but I wanted to talk through my positionality and then have you reflect on yours as well on this topic. And so I am from New England, those 6 northeastern states, specifically from Connecticut. And again, I identified and am identified as a white Jewish woman. in New England, which has a very specific experience with race and racism, right? Specific expulsion, very early expulsion of Native Americans from New England states, specific segregation and fights against integration. And you can think about the Boston busing riots that happened where white residents fought against integration, right? Very specifically racially hostile spaces in New England. Growing up in New England in the 80s and 90s, experienced anti-Semitism in terms of KKK marches in front of and around my synagogue, bullying, slurs, but this was not systemic racism that I'm going to talk about. This was not embedded in systems and policies, and that's really what we're talking about today. So I experienced something very different. I grew up in a majority Black, Indigenous, and people of color small city in New England. At the time I was growing up, there was heavy policing, policing specifically around drug use, work in the informal economy, some of that sex work, of which me and my family did not experience any direct effects of that policing, which I'll talk more about today. As I worked as a social worker in New York City, I became more aware of my racial privilege, white privilege, and my own racist actions embedded in systems I worked in as a social worker, whether that be healthcare, whether that be child welfare. And I've worked to educate myself to be as much of an ally as I can, while still acknowledging that I perpetrate racist acts, biased acts, and do my best to work against that, but kind of acknowledging where I am with that. And since 2016, I've taught classes on race and ethnicity and urban diversity. I've also published on the topic. And so I do have some expertise, but as I mentioned, my own positionality is as somebody with relative privilege in relationship to systematic racism that we're going to talk about and systemic racism. And so I want you to take a moment to reflect in some of the ways that I have kind of coming into this topic. And so I have a short 3-question poll that I've just released, which asks about what's your racial ethnic identity. This is anonymous and optional. So Black, Indigenous, people of color, or non-Hispanic, white, or other. Have you lived in a Black, Indigenous, people of color majority place? Yes, growing up. Yes, as an adult, or no, never. And have you had experiences with racism kind of against Black, Indigenous, and people of color? Have you experienced it? Have you witnessed it? Have you perpetrated it, or none to my knowledge? So I'm going to give people about 30 seconds, just in the interest of time, but I wanted to, again, kind of make visible my process in order to make it clear how I'm coming into this. I'd also like to say, if there's terminology I use that isn't clear, if there's something I say that doesn't sit well with you, please let me know in the chat, let the organizers know. There's also an anonymous evaluation at the end. And so I'm coming to this saying that this is a topic of which we all bring things to, and I will work to be as inclusive as possible, but if I'm not, with the bounds of time that we have. So again, however you feel comfortable, if there's something that you want to add or that you don't feel comfortable with, please let me know. Okay, so I'm going to end the poll in 5 seconds if anyone else wants to vote. So we can see who's here. Okay, so I am ending the poll now. Okay, so the majority of people here identify as non-Hispanic white, but about a third of people who responded said that they identify as Black, Indigenous, or people of color. Most people here either grew up or as an adult live in a Black or Indigenous, people of color majority place. Most people have witnessed racism against Black, Indigenous, and people of color. Almost 50% experienced it, and about 11% say that they perpetrated it. Okay, so that gives me a good idea, and hopefully this gives you an idea of who's in this space for this webinar. Sorry, okay, so sharing these results for a moment. So thank you to everyone who contributed. Okay. So in thinking about racial trauma, I wanted to situate us in the present in terms of pandemic disparity and violence. And as I'll talk about, this is not new, but this is kind of the form in which a lot of public discussion has happened about systemic racism and really opened a discussion about it in a lot of avenues. And I want to specifically talk about two areas of disparity and violence: pandemic health disparities and police killings and protests, and the violent responses to those protests against police killings. So pandemic health disparities, there's been a lot written about it. From the Center for Disease Control and Prevention. They released data in 2020 that said, and this is probably not new to you, that cases of COVID-19, hospitalizations, and deaths were disparate, right? Were disproportionate for people who were Black, Hispanic, and Latinx. For hospitalizations at rates 3 to 4 times those as people who are non-Hispanic white, right? And this has to do with the jobs that people have, how many people are direct service workers. This is probably very clear in terms of the state hospital and how some people moved remote and other people didn't. In terms of where people live, are people taking public transportation? All these kind of things played into risk, people's health access and level of health before the pandemic. So these kind of very clear disparities. There were also a number of high-profile police killings that sparked protests. The killing of George Floyd sparked a number of protests, but that kind of, his killing was one of many, not just during the pandemic, but before. And I want to speak specifically about the killing of Daniel Prude in Rochester, New York, in the midst of a mental health crisis. And specifically because there were a number of people that were killed in 2020 during the pandemic and before in mental health crisis, while in fact they had in some cases been seeking treatment. And so Rochester is a majority Black, Indigenous, and people of color city with a majority white police force. I have a 2-minute clip, which is about what happened to Daniel Prude. If you feel that this is not what you want to listen to, it talks about how he was killed and about the situation. It's about 2 minutes if you don't want to listen to it right now. So I'm just giving people a warning about that. And I want you to think about if you have experienced, witnessed, if you're concerned about something in terms of this, and how you think race and bias impacted what happened to him. So again, this is about a 2-minute clip.
Back in March, a man in Rochester, New York, named Joe Prude called 911. He wanted help with his brother, Daniel Prude. Daniel had a history of mental illness and was behaving erratically. Police arrived and immediately handcuffed him. They put a hood over his head and pinned his head and body to the ground. He was taken away in an ambulance. A week later, Daniel Prude died. His family's been trying to figure out what happened ever since. Yesterday, the family's lawyer received police footage of the events and shared it with local media. Protests soon followed. Before we get more details on this story, a note to listeners: the subject matter of what comes next is going to be disturbing. NPR's Liz Baker is covering this. She joins us from Rochester. Liz, good morning. What do we see in this footage?
Yeah, and like you said, it's really graphic. Prude, a Black man, is seen walking in the street. It's snowing. He's wearing no clothes. He's yelling at police officers. He spits at them. The police cover his head with a white bag, and Prude yells at the officers to give him their guns. Then, when Prude moves to stand up, the officers hold him down on his stomach and pin his head and his legs. And this is where the video gets especially hard to watch, because you can hear Prude making these awful noises as he struggles to breathe, and then he goes limp. At this point, the officers roll him onto his back. Prude seems unresponsive, and the EMTs arrive and immediately start chest compressions, and Prude's hands are still cuffed behind his back when they start those.
So his family's been trying to figure out what happened to him for 5 months. Why are we just hearing about this now?
Well, the lawyers for the family made a public records request for the footage. And so yesterday, after seeing that video, Prude's family held a press conference on the steps of Rochester City Hall. Here's the victim's brother, Joe Prude. He's the one who called police on his brother that night because he was concerned about his agitated mental state. Here he is.
I placed a phone call for my brother to get help, not for my brother to get lynched.
Okay. And for a little bit more context, Joe Prude had called 911 because he was concerned about his brother. Daniel Prude had gone for evaluation at a psychiatric facility earlier that day and had been discharged 2 hours later. They don't have a lot of space. And so he had looked for treatment and wasn't able to get it. And so what I'll ask is, in terms of these disparities and police violence, are these things that you have experienced or witnessed? And so I have another poll for you. Have you experienced this type of violence in relationships to police or policing? Have you witnessed it? Have you experienced this type of health disparity? Have you witnessed it either personal life or through work? Or have you neither witnessed or experienced? So take a moment just to put this in. And again, it took 6 months for records to be released. And so 6 months after he was killed, there was finally a public discussion and protest about it. But there's a lot of people, not just during the pandemic, who die during or killed during mental health crises. And so the pandemic has kind of pulled things together in terms of focus on this in a way that hopefully is helping to contribute to some change. Okay, so I'm going to close the poll in 5 seconds if anyone else would like to vote. Okay, so a small number of people have experienced violence and experienced disparity, these health disparities. A greater percentage have witnessed some of this violence or witnessed disparity, and about a third have neither witnessed nor experienced. And so I think that's going to help to think about how kind of we're coming to this from different perspectives in addition to our identity. So stepping back from the pandemic, I want to set up and define systemic racism. This may be not new to you, this may be a refresher, or this may be new. So I respect that this may sit differently with all of you, of course. So systemic racism really speaks to biased laws, policies, practices disproportionate against Black, Indigenous, and people of color in all sectors. Over time, this has absolutely shifted. And so this really speaks to systems that disproportionately disadvantage, have violence against, repress people in these groups. And this, again, is baked into the colonial histories of this country of expelling and killing Native Americans and of taking the labor and enslaving people from West Africa, kind of baked into historical foundations. Now, how that's played out over time has changed in terms of the changing social organization, the changing labor arrangements, mechanization of agriculture. All of these things have changed this. And so what we're going to look at is how systemic racism impacts a number of different areas. But the idea is that what has happened over the last 100 years is that this has shifted from being conscious, direct racism. So much has been kind of outlawed in terms of civil rights, that a lot of systemic racism does not require specifically racist intent and is in fact sometimes unconscious, but has racist outcomes, which I'm about to speak about in a moment. And so in terms of thinking about the broad-ranging impacts of systemic racism, kind of ground zero for a lot of modern social organizations in terms of outcomes and disparate outcomes are the lending and home ownership gap. And so a lot of home ownership in this country began to be broadly available in the 1930s to 60s. And that was supported by GI-backed home loans through the GI Bill and Federal Housing Authority, FHA-backed loans that went almost entirely to non-Hispanic white people. And so these kind of lending practices that were disproportionate led to segregated suburbs. And this has led to a continued, right, because the suburbs have very high rates of homeownership, has led to a continuing 25% gap between Black and white homeowners in terms of homeownership rates, which has led to continuing wealth gaps and things like that. What's also happened is it's led to education gaps, right, because public school is funded based on where you live by local tax dollars. And so this is segregated education, segregated resources to education, and contributed to job gaps, right? So differences in terms of where people are working, whether that's in the primary labor market with full-time jobs with good benefits that pay living wages versus the secondary labor market. This is, as I mentioned, impacted wealth accumulation. And so, right, the largest area of wealth accumulation is home ownership. That's the single largest piece of wealth that most people have, asset that people have in the United States. There's almost an over $100,000 wealth gap between white, non-Hispanic white people and Latinx, Hispanic, and Black people. And a lot of that has to do with different rates of home ownership. So that's a huge factor driving that inequality. And so I see a question from the question and answer. If we can't change the system, how do we change behaviors employed? And I think that's an excellent point, that so much of this is baked into the system. It doesn't actually require a racist person on top, even though there might be. It self-reproduces itself, and it self-reproduces racist outcomes. And it does require systemic change. And if this were one of my classes, I would talk about the ways in which systems can change. And I think that's an excellent point. This also is played out in terms of a health outcome gap, right? If health insurance is mainly coming from where people work, right? People with, there's a huge gap between Medicaid in terms of the reimbursement rates, in terms of providers versus private insurance from employers. So that's a huge gap. There's also issues of overdiagnosis, right? And overdiagnosis of Black, Indigenous, and people of color with schizophrenia spectrum disorders. I'm not sure if people see this. You can let me know in the chat if you see this kind of overdiagnosis versus white people are more diagnosed with mood disorders. And then over kind of institutionalization in terms of state hospitals, and then under treatment in terms of access to community treatment. Once people are not in hospitals, less access to those community treatment services. And then rates of over-policing, of sentencing and incarceration. There's been a lot written in the last 20 years that since the 1980s, there has been mass incarceration disproportionately of people for nonviolent drug and property related activities. And so this type of system, and these are just some of the gaps and disparities that exist, but this is baked into, again, not necessarily consciously. And I'll ask if you have seen these gaps or disparities. Lending, homeownership gaps, education and job gap, wealth accumulation gap, over under diagnosis. This can be personally, this can be professionally, over policing, sentencing, incarceration. So take a moment to see if, you know, what kind of stands out to you as something you've seen or maybe something you haven't seen. So I'm going to close the poll in about 5 seconds, just again, in the interest of time. Anybody else would like to vote? Okay, I'm going to close the poll now and share. So a lot of people are seeing over policing, sentencing, incarceration, job and education gap. There's a wonderful piece by Nicole Hannah-Jones of the 1519 project from the New York Times about how it's not really an achievement gap, it's really about segregation and the need for integration. And so sometimes some of these gaps just need to be reframed. So I'm going to stop sharing. So it seems like a number of these gaps disparities are familiar to you. Now, because as I mentioned, systemic racism doesn't necessarily, and since the civil rights movement can't really be explicit, right? A lot of it has to do with implicit bias. So the systems are kind of built with discrimination and different accesses to opportunities and outcomes, but this plays out in terms of implicit bias and interactions. And I'm going to talk about 3 forms of implicit bias. The first is micro-invalidation. And this is to invalidate or deny thoughts or feelings. So a number of you said you've seen disproportionate policing, sentencing, incarceration. But if somebody says, oh, I was stopped by the police, I think it was because of my identity. And you say, no, it's not because of your identity. That's not what I see. That's invalidating someone's experience who may have been stopped multiple times, who maybe has a different understanding of policing and interaction with police. Then there's also micro insults. And so these are rude or insensitive behaviors or statements of racial identity or heritage, right? So saying, for example, all Latino people are foreign. I've had the experience of seeing a number of people, for example, of Asian heritage and saying, where are you from? You're not from here, regardless of someone's experience. So invalidating people's experiences and kind of saying, well, you're not really from here. So that's kind of micro insults. And then micro assaults. Those are verbal attacks, avoidant behavior, for example, avoiding eye contact or crossing the street to avoid. And so I'm going to do another short poll about implicit bias. Have you witnessed, perpetrated either, or are you unsure, or no, neither? And I see there's another QA. So I see another question, yeah, about Jim Crow laws. Yeah, I mentioned in Michelle Alexander's book, The New Jim Crow, specifically about how mass incarceration is an extension of Jim Crow, how if you have a felony, you can't vote, you can't have a lot of rights in terms of access to benefits, and that basically removes people's civil rights, which is very similar to Jim Crow, and how in effect it reestablishes restrictions under Jim Crow. So I highly recommend The New Jim Crow if anybody hasn't looked at that. So thank you for bringing that up. So I'm going to end the poll in 5 seconds if anyone else hasn't voted. Okay. Excellent. Okay, so many of you have witnessed these actions. And again, these are ways in which people may be meant to feel that you're not safe, that providers are not safe to talk to, that people don't feel respected, and kind of go hand in hand with systemic racism's disparities and gaps. Okay. So now I'm going to talk about disproportionately racialized experiences, which is going to lead into the discussion of trauma. Sorry, I have a little bit of sun that's coming in that I didn't expect. And so I apologize for that in terms of the screen. I'm trying to reduce that. I hope that's a little bit better. So disproportionately racialized experiences are not things that are unique to people who are Black, Indigenous, and people of color, but things that are disproportionate based on systemic racism and bias. And so a lot of times, we talk about bad outcomes that people have, or some of the experiences I'm going to talk about in terms of bad choices that people make. But I want to talk about it in light of the systemic racism that I just kind of laid out and was just discussed. And so some of the kind of negative outcomes, and I want you to think if any of these are similar with people in the state hospitals, people that you've worked with. And so, for example, cyclical evictions. People have written a lot about how evictions are going to be rising due to COVID, but there are millions of people who kind of cycle in and out of evictions every year, every couple of years, mostly in Black, Indigenous, and people of color, dense parts of cities. There's a great book by Matthew Desmond called Evicted, which kind of details that process and what that looks like for families. That leads to higher rates of homelessness, right? Whether that's being doubled up, being in shelter, and then higher involvement in the children's system of care. And that can be removal, that can be placement, right? And most people in the children's system of care, it's not for abuse, it's for neglect. And that's disproportionately of people from lower socioeconomic families. So if you're disproportionately being evicted, having higher levels of homelessness, more likely to be renters, more likely to be in the secondary job market, all of those things contribute to higher rates of system of care involvement. And there's been a lot about how disproportionate those rates are. And again, this feeds into some of the ways in which the disparities and gaps kind of play out in terms of outcomes. Thank you. We have a book recommendation, Cast: The Origins of Our Discontents by Isabel Wilkerson. Thank you for that recommendation. So this also contributes to, as I mentioned, education gaps in terms of wealth, lead people to be in parts of cities with low employment rates, low transportation rates. People talk about the mismatch between where people live and where jobs are. Higher rates of informal economy involvement. That could be things that are, and a lot of that is either civil offenses, it could be misdemeanor things, it could be sex work, it could be work in around illicit substances. There are also higher rates of gang involvement. Again, this is not only, but this is disproportionate. And this again has to do with, in terms of gang involvement, it has to do with economics, right? Having a source of income. It could also have to do with feeling unsafe. There was a really wonderful piece written about kids in high schools on the south side of Chicago joining gangs, not doing any type of illegal activity, but for safety walking to school in very disinvested neighborhoods, right? And then higher rates of being ticketed, arrested, and jailed, which we are going to focus on for a lot more of this presentation. And I want you to think, and I'm going to do this quickly to keep the polls moving. Are any of these common experiences with patients that you have familiarity with? Experiences with evictions, homelessness, with the children's system of care, either with their children or being involved themselves, informal economic activity, gang involvement, being ticketed, arrested, or jailed, or no, these are not common experiences. So take a moment to look at these and see what of these are common experiences. So I'm just going to leave this open for another, let's say 10 seconds if anybody else wants to vote, but take a moment to think. And I want you to think, are there some of these experiences that you maybe don't know about, that maybe doesn't come up during the assessment or isn't really screened for, but that maybe you'd like to learn more about? Okay, so I'm going to close the poll now. Thank you to everyone who voted. And so really people are saying homelessness and being ticketed, arrested, or jailed. And I'd be really interested to know whether people are screening for children's system of care, informal economy involvement, and evictions, because those things are highly related, but sometimes just not asked. So that's something to really think about. Okay. So now I'm going to shift to thinking about one type of impact of systemic racism. Oh, I'm so sorry. That was supposed to be set up to allow people to have multiple responses. That must have just been single. I apologize, Kathleen. So that poll was set up in not a great way. You couldn't select more than one. I apologize. That was all of them. Okay, so people saw many more. Excellent. People could just select one. I apologize. Thank you guys for putting in the chat. I apologize for that. Okay, a lot of you are saying all of them. Margaret, Kathleen, Monica. Okay, thank you for sharing. I appreciate that. Okay, and then another all of them in the Q&A. So now we're going to talk a little bit about disproportionate contact with the police plus the criminal legal system. I like to say criminal legal system and not criminal justice system, because what we're going to talk about is a lot of injustice. And by saying it's the criminal justice system, I think isn't quite right in terms of the impact for a lot of people. And so at the interaction between people who are Black, Indigenous, and people of color and people with serious mental health conditions, you can think about what happened to Daniel Prude. right? There's a lot of over-policing. And over-policing is basically policing for things that are misdemeanors and civil offenses. And those are things that are not felonies, they're not violent, and generally would have sentences under 6 months. So being ticketed, for example, for open containers, maybe being arrested on a misdemeanor around loitering, things like that. And so the rates for people who are BIPOC and have serious mental health conditions that are profiled and stopped is disproportionate. People who are searched and have force used against them, people who are arrested and then incarcerated. And for people with serious mental health conditions, the rate compared to the rate in the general population is 4 to 6 times as estimated. And most people with serious mental health conditions, right, they're being jailed, stopped, searched, arrested, and incarcerated for misdemeanors and civil offenses. That's not entirely, but that is disproportionate what people are being policed for. And at the same time, they're being underprotected. So over-policed, but underprotected. And so this means in terms of access to emergency responders. So if you think about what happened to Daniel Prude, he had tried to access psychiatric care and was, turfed just an hour or two later, and then ended up when his brother called 911 for an ambulance, had police come, right, and violently respond and eventually kill him. That also speaks to lower neighborhood resources. So thinking about where are providers located, are there sufficient medical providers, mental health providers in the community for people? Oftentimes not, so there's an under-resourcing. And think about what are some examples of over-policing that you've seen? Things that have been over-policed. And a good example that I can think of in terms of over-policing is, for example, people get tickets, for example, for, I lived in New York City for a long time, for jumping turnstiles for the subway, right? So they'll get ticketed, they get fined, they can't pay a fine, and then they have a bench warrant to be arrested. So that's like a classic case of over-policing. And what's often said to be over-policing is it's really policing marginality and policing poverty and policing people who are systemically discriminated against. Okay, so take a moment to kind of think about, because a number of people identified policing as an issue. So take a moment to continue thinking about that. So for people who have disproportionate contact with the police, that means disproportionate violence. And oftentimes that can contribute to racial trauma. And so different types of police violence have to do with neglect. And so, for example, I mentioned under-resourcing. If you're in trouble, if something's happening and you call the police and they don't respond, right? Or you ask for something and it's not responded to, that's a form of neglect, and that's incredibly scary for people. So that's one form. There's also psychological. So for example, people having slurs used, people being taunted, things like that, that's form of psychological violence. There's also sexual violence, which can be forcible contact, that's rape or sexual assault. And then physical violence with and without a weapon. So that can be hitting, kicking, slapping, use of a taser, use of a baton, use of a gun. Right, and what happened to Daniel Prude, it was a spit hood that was used. So he wasn't shot, but he suffocated in a spit hood, which a number of human rights organizations have denounced as an inhumane thing to be used. And so these different forms of violences by police can constitute racial trauma. And I'm going to use SAMHSA's 3-part trauma framework of event, experience, and effect to think about how these things can be racially traumatic. So they can be direct, right? Somebody can be, shot by police, or it can be vicarious. You can watch videos of this, which can absolutely be traumatizing and very stressful. These things are experienced and there are reactions. Common reactions are feeling dehumanized, feeling criminalized, And this can lead to long-term effects. And these effects are very similar to effects of PTSD. So hypervigilance, aggression, avoidance, re-experiencing. And as I'm going to talk about in a moment, they're often not talked about as traumas and not really considered in the framework of trauma. And so I have here, so policing and child support laws, domestic violence victims of color whose bruising injuries may manifest differently than lighter skinned people. Police may not recognize abuse of the person calling for help. And that's a form of neglect. Yeah, exactly. So just not acknowledging that something is happening. And there's been a lot of things in terms of, for example, violence against sex workers, as I mentioned, right, being kind of not allowed to be in the primary labor market, not acknowledging when people who work in sex work are abused, right? People are sexually assaulted, people are physically assaulted, and not doing anything about that is a really important form of neglect. So thank you for bringing that up, Dawn. Yeah, and people being afraid to call the police due to lack of trust. Absolutely. Which is part of that underprotection and over-policing. So when people do need help, they're not going to the police. And so I'm actually, in the interest of time, going to skip over this case just so we have time to do everything. This is going to be in the presentation that I shared with you, but we're not going to talk about it. It's kind of similar to what happened to Daniel Prude, but the person ended up living. So we're not going to really do it, but this is Alan Payon, who was shot during a mental health crisis. He lived. It was a story that was run in the New York Times and on This American Life, which I highly recommend. And so just again, in the interest of time to go through the content, we're not gonna talk about it, but I'm sharing those pieces if you want to take a look at them later. So racial trauma is under-recognized. So whether it is, as Dawn mentioned, in the child welfare system, or in terms of domestic violence not being recognized, and there are some barriers that have been identified in terms of a lack of identification of racial traumas. The example I gave you was around policing and police abuse and neglect, but there are some barriers. First, there's a lack of awareness among clients of what is considered traumatic. And so in the case of over-policing, perhaps being stopped by the police, being yelled slurs, being ticketed heavily by the police, having physical violence, being pushed, being hit, people may see that in their communities all the time and have it happen multiple times, and that's never discussed as being traumatic. And so when somebody's asked at an intake, what's trauma? Have you experienced trauma? It's like, that doesn't really come up as trauma. It's not an example of trauma. And so it gets missed by the individual not bringing it up. There's also a lack of awareness among clinicians of racial trauma. And so, for example, I'll give an example from I'm in the Psychiatric Rehabilitation Department. In 2020, we were trying to do a webinar on policing and trauma. And somebody in the department was like, that's not necessary. There's no issue in supportive housing among people in the community with serious mental health conditions living in a large city with negative police interactions, which is absolutely not true. The ACLU had written a report on that city and over policing and had mentioned people with serious mental health conditions. And so there's just a lack of awareness. People don't live in the same places as the people that they provide services to. Oftentimes clinicians live more in the suburbs. People who receive services live more in cities. And there's just a lack of understanding of how people live in those places and that kind of disconnect. There's also a discomfort with clinicians with conversations about race, with asking about race, asking about racism, acknowledging it. And this, from the literature, this is not everyone, but this is what's been found in part because of the socioeconomic differences that are common between clinicians and people in behavioral health services. There's also insufficient measures for assessment. So what's often used to measure checklists in terms of trauma exposures or PTSD misses trauma, right? Just misses racial trauma and racism, which I'm going to talk about. And there are some tools being developed. And I'll ask, have you witnessed any of these barriers? So Okay, so a lack of cultural understanding. And I think that goes to the discomfort with clinicians, with conversations, a lack of awareness. Absolutely. So Margaret, you're saying yes. Because this has been written about quite a bit in the literature. But the question of how this plays out in individual institutions, it matters who are the clinicians, who are the patients, what's the location. But this is definitely something that's important, and why we thought it was important to do this. Even though there was a prep webinar on trauma-informed services, there really isn't enough of a discussion about racial trauma and the under-recognition of it. So now I want to talk about screening for racial trauma and the different ways it can be screened for, which is important. Because as a lot of you mentioned, those conditions of homelessness, of eviction, of informal economy involvement, of policing, those things are highly stressful and may be traumatic events that are experienced traumatically and have long-term effects, but may not be being recognized, and that can really influence how services are provided. And so in terms of assessment for trauma, right, in New Jersey, universal trauma screening, this is something that is sweeping the nation in terms of a focus on trauma-informed services, right? And it's recommended that this happens at initial assessment, and also that there are specific examples and questions offered to show people what are traumas, so that it's not just asking them, have you experienced trauma? However, it's often asked as a single question. And I'll just ask if anybody has this experience where there's a single trauma question that's asked. And this, I work in community support services, offering training and technical assistance. And the question we have on our assessment is, have you experienced any traumatic events or physical, emotional, or sexual abuse? So any trauma events or abuse. And the abuse is really to speak, I think, to ACEs and the inclusion of adverse childhood experiences since the 90s. And so this question, right, it doesn't give examples, it's not specific. However, there's been moves to use trauma checklists as a way to give people specific examples so that you don't just ask them one broad question. Now, some of the problems with this is that the specific examples are based on the DSM-5 PTSD criteria, which I mentioned is pretty biased against racial trauma. And so it'll ask things that are generally considered to be common stressors. So being physically attacked, having a sudden death, yeah, Margaret, it is a complex question for individuals in distress to absorb. Exactly, if they're coming in, especially in the state hospitals, in periods of distress, right? And maybe they've been brought in by police, which is a whole other thing, that people are being perhaps restrained, brought in by police with perhaps traumatic police experiences. Perhaps the thing that brought them to the state hospital was a trauma, a reminder of a trauma. Well, that's interesting. Yeah, so the checklists don't, some of it has to do with witnessing and not necessarily experiencing. It does depend on the checklist. But as I mentioned, vicarious trauma, secondary trauma, this is something that's considered in terms of racial trauma. So that's a great question, Monica. So I want to talk about two specific tools that I think are helpful for helping to bring out whether it's direct trauma, secondary vicarious trauma related to systemic racism. So I'm gonna to skip over that. So I have two things. One is a recommended kind of use of a checklist and a survey. And so since 2018, there has been a checklist used at Incora admissions, which is an expanded life events checklist. The initial life events checklist was based on the DSM-5 criteria, and again, asked about ACEs, asked about death, illness, childhood instability. However, based on feedback, a member of the state hospital psych rehab initiative expanded the checklist to include highly racialized forms of trauma. And I'm going to put this here in the chat to show you the expanded checklist. And some of the items that were added are, have you ever experienced police brutality or police harassment? Have you been homeless? Have you ever had a period of time when you didn't have enough to eat? And have you ever felt in danger for your life because of race, ethnicity, and gender? There's absolutely more to add. There isn't a question about the foster care system or children's system of care, but these are, again, experiences, as I've mentioned, that are disproportionate based on race and ethnicity. And these are things that absolutely are impacted by systemic racism. And so this is the Ancora. And has anybody used this? I don't know if anyone here is at Ancora, but have you used this? Again, this should be implemented universally. Have you seen it in forms, in terms of people's charts? The goal of this is to give people, to include more forms of trauma that are racialized. Okay, so Christopher, GPPH, is that Greystone? I think, yes. Let me know. Yes, excellent. All these state hospital acronyms, excellent. Great, that's great to hear that it's at Greystone. So there's a movement towards moving it more system-wide, and the goal is eventually to have this include more forms of racialized trauma. So that's one example of just added missions, giving people the opportunity, and even the opportunity at some point to update. Because I think, Monica, your example that people are coming in, they haven't had chance to decompress and they're being asked all these things at once. And this might be something to revisit at some point to give people another opportunity. If somebody on the expanded checklist identifies, for example, some type of racialized trauma, something in relationship to racism, the PTSD screens, right, because hospital populations have really high rates of PTSD, but low rates of diagnosis with PTSD. It's a huge problem. So if somebody is being screened for PTSD, if these are concerned about symptoms, hypervigilance, re-experiencing, avoidance, the PTSD screens that are used are not very good at identifying racial trauma as the cause of PTSD. And so the University of Connecticut came up with and has validated the Racial Ethnic Stress and Trauma Survey, which I'm going to share in the chat and is clickable in the presentation. And what this does is it's an interviewer survey that starts not by asking about PTSD, but asking about experiences of racism. Overt, covert, vicarious. And so these are open-ended questions. And so this is an overt one. Can you share with me a time you were impacted by racism? And then a little later, I'm specifically interested in any experiences where you were concerned about your safety or the event was very upsetting. So once people start to think about these experiences, the second part of it is the criteria for PTSD diagnosis. And these are closed-ended questions. So for avoidance, so it's all for criteria A for PTSD. Have you been trying hard not to think about upsetting racist experiences you've had? Yes or no? So it's PTSD criteria, but focused on racism. And so you're priming people to be thinking about it, again, because of how the tools often ignore this type of trauma. And so what I want to do is to take a moment to sit with these tools. I had in the chat that someone says, Christopher said that he's seen the expanded trauma checklist. I'd like you to think about if you've seen the checklist, if you've seen a similar idea, if you've seen the racial ethnic trauma survey. That's interesting. Wait till the end of the presentation and remind me again at the end of the presentation. I'm sorry that you can't access them. So these are specifically helping people to identify these things as trauma and to think about what the long-term impacts are in terms of perhaps PTSD, because again, this population in state hospitals has very high rates of undiagnosed PTSD. And so what do you think responses? So if somebody says, yes, I've experienced police brutality or police harassment. Yes, I've had a period of time when I didn't have enough to eat. Yes, I felt in danger because of my race or ethnicity. What can that actually do? How can those responses be used to make care more responsive to needs? I'm going to throw that out to you as something open-ended. All of my questions have been closed-ended. How could that actually do something to change services? Because that's the goal of this, right? Maybe to help people get a diagnosis if it's helpful to them and get treatment, but really thinking about how can you inform, because that's what trauma-informed services are, to help inform services, knowing about trauma to help kind of provide services that are not re-traumatizing and that are supportive of people. Oh, and thank you. So the checklist will be available. That's great with the evaluation. Wonderful, thank you. So how could this actually help to change services in the hospitals? And all of you are in different programs, at different kind of levels, but how would knowing about some of these things be helpful in providing services? An example that I've had from somebody who's used the checklist is that it's changed policies around food. There were a lot of people that were assessed to have a time when they hadn't had a lot to eat, and it changed policies of being able to get more food and not withholding food from people. So Margaret, thinking about placement, right? So, okay, yeah, so people have had a lot of experiences of systemic racism, of racial trauma, being sensitive to who someone's roomed with. And the challenging part about that is how to identify, is it by what people have said in terms of racism, but that's something to think about. How does that impact rooming? And should there be an emphasis on giving people the option to be roomed with people from similar racial and ethnic backgrounds? That happens in colleges. Sometimes people request to be for fear of racism, request to be with people from similar backgrounds. Is that something that might be helpful? Mm-hmm. Anybody else? How might knowing about some of these things impact services? That can be policy level or just kind of how you individually work with someone. So I'm going to give people one more minute. It's not magic. And I think that's a great point, Margaret, that like none of this is magic. Knowing about it doesn't change the structures. It doesn't necessarily allow you to change the way the hospitals kind of operate. And again, because of people's experiences in terms of policing, the use of restraints, things like that can be absolutely reminders of things that have happened previously. And so all of these kind of intersecting systems are really challenging actually working in the hospitals in terms of being able to be responsive, but then also needing to kind of go about the business of the hospital. So that's a great point, that it isn't magic. So I want to talk about 3 resources that I think might be helpful and that are freely available. The first is implicit association tests that are through Project Implicit. These are free, and what they do is they are helpful to locate bias that may be non-conscious. And so there's one for specifically on skin tone, light skin, dark skin. So it's quickly flashing photos with associations, and that's a good way to kind of identify bias. And for programs, maybe for administrators, for clinicians, this might be a way. I've used this myself to identify different biases. There's also sexual orientations. There's lots of different association tests. So that's a way to kind of identify. Then there's implicit bias modules, and this is from the Kirwan Institute at Ohio State. These are free, and they're short 5-minute modules on implicit bias in behavioral health, what it is, how it may influence relations, and what you can do to kind of reduce those biases. So that's a really nice, very short 4-part series specifically on implicit bias. Then there's Think Cultural Health, and this is from Health and Human Services. The goal is to increase racism knowledge for practice. It's self-paced modules. It's about 4 different modules that are 4 to 5.5 hours. There are some CEUs available depending on your licensing, but there's also certificates of participation. They have great handouts and resources. Some might be useful for staff. This has been a really wonderful resource that has been well received by providers in the CSS community. So those are 3 resources. If there are any other resources, I know there were some books that were mentioned that you think are helpful on these topics, please, please, please put them in the chat. Feel free to share them. I know we are running low on time, and so I wanted to turn things over very quickly to questions, but I think we only have a few minutes left. So if anyone has any questions, I'm happy to take them. Yes, absolutely. I'm providing the slides again. So the links should be clickable there if there's anything you want. I also have my contact information, which is in the slides. And so if there's something that doesn't work, please feel free to reach out to me or if you have any questions.
And also, thank you, Shelley. If I could just jump in for one moment, this is Dawn, just to let you know that as Jen has just said in the chat, all of these resources will also be available when you respond to our feedback evaluation. So you also see, you know, all the handouts that Shelley has referenced, the slides, and then again on our website, there will be a link where you can view a recording of this live webinar. So we have about 1 minute left. Does anybody have any last parting questions for Shelley? And here is her contact information. Obviously, if you would like to reach out to her offline, I'm sure she would be more than happy to take your questions and comments.
I'd also like to point out that I have 3 pages of references with clickable links if anybody is interested in learning more about any of these topics. So there's in-text slides, and then you can kind of click to learn more.
Thank you, Shelley. Oh, sorry, everyone. My cat is now making an appearance in the webinar. So that is it for today's prep webinar. Once again, I want to thank all of you for attending and thank you for your interactions and your honesty and your participation in the polls. We greatly appreciate that and appreciate your vulnerability and willingness to share. And again, a special thank you to Dr. Buchbinder for joining us today. And we hope you'll come back at a later date to maybe talk more about this topic because it really is, you know, so comprehensive and almost a disservice to only allot an hour to it, but we're really happy to have had you here to kind of introduce this topic to our state hospital folks and to reinforce this as a very important clinical topic that we need to address and that has been under addressed. So thank you.
Yeah, thank you, everyone. Thank you for your participation. And I agree that this just needs to be a longer discussion, not just one topic. And in community support services, we're working to embed this in not just kind of a unit of something, but in everything that we talk about. And so I hope that these kind of issues, not focusing on kind of bad outcomes, bad choices, but thinking about systems, really important. So thank you again so much. And I hope that this is helpful. And I hope to see some of you again in a different forum.
Thank you all.